Looks very diluted. You going cheap on me, Luis? This is Florida. We don't use concentrate, damn it. Just messing with you. All right. Any questions from our audience about this Duke laser disc repair surgery? Can you all see the incision, Zach? You have enough light to see it?
Yeah, we can see it.
It's about as wide as my fingernail. That's, every one of our patients has the same incision. It's really small. And notice how it comes off from the side, not through the middle like every other surgeon, because it's a very special surgery. All right. So you want to keep pressure on the paraspinous muscle because you don't want it bleeding. Push down. You don't want it bleeding, not because you're worried about the amount of blood they're losing, the patient's losing, but you're worried about a blood clot forming in the muscle. Why does it matter? Well, just don't mess with that too much. The blood clot in the muscle is not going to do anything bad permanently, but what it does do, let's see, can we drop the fluoro? You're all the way down. Table up a smidge then. Maybe zoom out a little bit. Why don't you zoom out a little? Come to me. What the blood clot would do in the muscle is it's going to irritate the muscle. Okay? And irritation means pain and muscle spasms during the healing period. So I don't want my patients to suffer from their surgery shot. I want them to suffer as little as possible. So if you let the blood sit there as a clot in the muscle, it will break down over the next month or two. And as it breaks down into liquid, kind of a reddish-brown liquid, that reddish-brown liquid is going to cause inflammation. It's going to precipitate inflammation in the muscle. And patients will get muscle spasms in their muscles from that reddish-brown liquid. Okay? We call it a seroma. Shot. Anyway, we don't want a seroma, but seromas happen after all surgeries, but we want to minimize the amount of seroma. Shot? If we can minimize the amount of seroma, we can minimize the discomfort for the patient during the healing process. So one of the things I learned very early on in doing this surgery shot and every other surgery I do is that if you can protect the muscles from injury or from irritation while the patient's healing, they're going to have a much better healing experience. Shot. 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 All right, we're inside that disc pretty good. You can see the slippage of one bone on the other. Top one is sliding forward on the bottom one. Let me get one more shot there. Okay, good. And I'm going to go ahead and advance this. Good. Let's go that. Now, can you all see this, Zach? You see this?
We can see it.
This is my straw for my strawberry milkshake after the surgery. I'm just kidding. It's for my chocolate milkshake. I don't drink strawberry milkshakes. But that is what we do the whole surgery through, is that metal straw. Ask your spine surgeon if they can do your back surgery through a tube the width of a metal straw. I already know what the answer is. The answer is no. That would be like asking if you can go down to the marina and have a ride in the nuclear submarine. The answer is no, because there are no nuclear submarines at the marina, and if there was, they still wouldn't let you on. Unless, of course, you're in the Navy and you work on a nuclear submarine, then maybe you could. But there aren't any spine surgeons around that know how to do this technology. It's so new and advanced. There's only a few in the world, shot. All right. So I'm actually advancing the dilator with that, which I don't want to do any further because I'm already near the front of the disc. So I want to pull it back a little bit and then take a shot. Yeah, it's
We have
bothering
a
me.
question.
And then probably bring this forward a little bit. Shot. That's it. Shot. Perfect. Thank you. That's beautiful. I don't know why it just keeps peeling up. Good? Thanks. All right, so I'm just getting a little steamy in here. So we got the air conditioning unit fixed at the surgery center this week, thanks to the hard work of Sunny, who is our network administrator, head of IT, but also air conditioning coordinator, repair guy extraordinaire. I say that laughingly because in a small business like ours, which we are a small business, under 100 employees, we don't have a dedicated air conditioning person, right? So, you know, what it highlights is the fact that everybody here actually carries multiple responsibilities, right? And for example, Mike here is now our new official laser technician. High five. Smack. Good job, man. Seriously, good job. And I like it when everybody works as a team to pick up the slack, and because God knows I can't afford to hire a laser tech full time just for the 5 surgeries a week we do. Right? All right. Laser on.
We have a question.
Sure.
We have a viewer who says, I'm still waiting for my spinal cord stimulator to put in. They're taking a long time to do it. Now they want me to do physical therapy first. I've had these problems for years, and I don't think it would help. What would you recommend doing?
Okay, so we have somebody who says, listen, I'm scheduled for a spinal cord stimulator, and now I'm being told, hold the horses. We can't do the spinal cord stimulator. The insurance company basically wants me to do all this therapy first. What do you recommend, Dr. Duke-Majan? Here's what I recommend. I recommend you get your MRI and send it to me. Let me look at your MRI and see if one of these laser surgeries would work for you. Because this is a lot better option than a spinal cord stimulator, by far. You understand what I'm saying? It's the difference between sitting down and having dinner in your forest and having a filet mignon versus eating grubs out of a tree. You know what grubs are? I hope so. That's the difference. Spinal cord stimulators are your last worst option for any patient. And the only reason why people are being told to get a spinal cord stimulator is because a lot of these people who are getting recommended for it are being recommended by doctors based on economic reasons. And what I mean by that is the doctors that put in spinal cord stimulators, a lot of them are interventional pain management doctors. That is the highest paying, most lucrative procedure they could possibly do. In the old days, before they were paid well to do spinal cord stimulators, they would actually send patients to the surgeon to see whether the problem could be fixed in a real way. And nowadays, since all these doctors are doing spinal cord stimulators and making a lot of money, they don't want to send patients for a real surgery. They just want to capitalize on the spinal cord stimulator program. I know it's a horrible thing to say, and it may bother you for me to say that, but I'm just telling you the truth. Now, it could be that your doctors have exhausted everything else, and spinal cord stimulator is your best option. But let me help you make that decision. Just get a copy of your MRI, send it in for a review, let me look over it, put the big question as, should I get a spinal cord stimulator, or is there a fix for my problem? A spinal cord stimulator, for those of you who don't know what it is, it's basically like a pacemaker being stuck in your body. There's a battery, there's a wire, and it goes to a permanent lead that goes over your spinal cord. Now the problem is that the pain control is not great with them, okay? And if it is good, it doesn't last. And the reason it doesn't last is you get the scar tissue that forms between the electrodes and the dura covering the spinal cord. And the other reason it doesn't last is because the leads slip off the spinal cord and they slip down and they migrate. So they move off of where they're supposed to be. Very easy. Comes with normal movements of people. They're just bending and twisting, playing sports. The other problem is, of course, the batteries run out. You got to have it either rechargeable or you got to have it taken out and replaced. So I personally don't like spinal cord stimulators unless the patient doesn't have any other options. And what I mean by that is if there's a way to fix your problem with surgery, like a laser surgery that I'm doing now, why would you have a spinal cord stimulator put in? It's the wrong thing to do. You want to get your fix like this, not have to worry about a machine being stuck in your body. Now, for somebody who's got, had back surgeries a couple of times and there's no other surgery that could possibly be done because they're so, weak and frail and they're older or they have a bad heart and they can't undergo real surgery, then you go put a spinal cord stimulator in. Unfortunately, though, the reality is there's been an explosion in implantation of spinal cord stimulators around the United States because Medicare pays $34,000 to have it done. And honestly, it's a good fair price, but it's unfortunately motivating a lot of doctors to just put them in rather than actually getting the patient fixed. So if you're asking me what I would recommend that you and I meet. I don't even charge for it. Free visit, free consultation. I do it for everybody that wants it. And let me look at your back or neck, whatever we're talking about. I suppose it's your back. And let me talk to you and see where your pain is, and let me look at your MRI. And I'll tell you if a spinal cord stimulator trial is your best option. You have to go through the trial first. I'm sure they told you that, where they're going to put it in for 5 days probably and see how it works for you, which is, I think, the right thing to do. You always want to do a trial before you put a permanent in. But I think the trial is probably premature based on what I'm hearing, and that you should not have it done at all. You understand what I'm saying? Think about a spinal cord stimulator implantation as being like declaring bankruptcy in your life, financially, declaring bankruptcy. You want to wait to declare bankruptcy as your last option. You don't want to, if you owe somebody $200, you don't want to go and declare bankruptcy for $200. It doesn't make sense. You just figure out a way to get the $200, whether you borrow it or, work it off. You get it paid, but you don't declare bankruptcy. So putting a spinal cord stimulator in for somebody's back pain or leg pain, it should be the last option. Usually problems are fixable. And so let's get your problem fixed rather than try to cover it up with some electrical signals and magnetic signals with a device that, is not without risk for putting it in. I know there are people who are paralyzed from those things, or infections on their spine from those things, or a lot of bad things can happen as a result of that stimulator being put in, especially if it's being put in by a pain management doctor. There's just a lot of pain management doctors sticking them in because they make so much damn money for doing it. So I just don't think it's the right reason to put it in. You got to have a really, really good reason to put it in. And I'm happy to talk to you about it. Again, no charge. Just submit your MRI for review. Talk to Lauren. Just tell her what it is you're looking for and my opinion on that, and I'll be happy to give it to you for free. All right, so we're just working our way out of the disc. You can see the tear. Very, very common. Every single one of these, I've done 1,000 of them, always have a tear. And it's the tear right here. Look at the pink granulation tissue. You see it right there? That little spot right there, embedded in there, right there. I'm going to move. You see that? That is the source of pain right there. There's little nerve fibers in there. It's like a little pressure spot, like a little mine, a claymore mine. You trigger it and it sets off a blast of pain. Anyway, I zap it away and the pain goes away. You can see more of it right there. It's right inside the tear. That is the source of back pain and neck pain in people with herniated disc. Oh yeah. There's even more right there. We're going to get it all. Don't worry. All right. Those are good questions. Any more questions? What time is our seminar? 5 o'clock?
5:30.
5:30? All right. So Dr. Patel is giving a seminar tonight. My partner is giving a seminar on spinal cord stimulators. So we do put spinal cord stimulators in at Duke Spine Institute, but only in patients who can't have a normal surgery to get rid of the pain. People who are too sick, too frail, they have bad hearts, they are just too old, you know, not like, oh, you're too old, you're 75 years old, but you're healthy as an ox, we're putting a spinal cord stimulator in. No, we're talking about people that are on COPD, that are high risk for any kind of surgery. Those are people that would do better with a spinal cord stimulator because they can't have a normal spine surgery. Now, the Duke laser disc repair is a game changer. Wouldn't you say that, Dr. Santiago? Because the anesthesia for this case is just the same as a spinal cord stimulator, so you can actually get your back fixed rather than covering it up. Problem is, nobody really knows how to do these surgeries. Yeah. So of course the companies that make the spinal cord stimulators like St. Jude or Medtronic, right? Those guys go out and spend millions of dollars every year on training pain doctors to put spinal cord stimulators in. They go to their practice and this is what the conversation sounds like. Hi, Dr. Schmorgelbummer. I'm with Medtronic. Would you like to learn how to put a spinal cord stimulator in a patient so you can start doing that as part of your practice? And the doctor goes, I don't know. Why would I want to do that? And the rep says, because you can make $1 gazillion sticking these things in people, who, even though they don't need it. And the doctor goes, really? That sounds good to me. How do I sign up? Well, you just have to go to one of our courses and we'll teach you. Unfortunately, that's what happens. May not like to hear it, but that is what happens. Trust me. Seen it 100 times. Yeah, all the expenses are covered. Steak dinner, alcohol, good times, good times. But, you know, there's nothing wrong, in my opinion, with learning how to put a spinal cord stimulator in or taking one out. There's nothing wrong with putting in a spinal cord stimulator in a patient where it's, in my opinion, what I call medically necessary, meaning that that's the procedure of choice for that patient. Stand by. There's nothing wrong with it. But the problem is it's abused. It's being abused right now by a lot of doctors. And so I just caution people when they say, oh, I'm going to get a spinal cord stimulator put in. Just be careful and talk to me first, and I'll help you out. I'll tell you, first person to tell you the money's good. But you know what? That's the wrong reason to do a treatment on somebody is because the money's good. You do a treatment on someone because it's the best treatment for that person. Unfortunately, not everyone thinks that way. But our doctors here are very ethical. Dr. Patel is extremely ethical. Dr. Santiago, extremely ethical. All of our doctors are very ethical doctors. We do what's right for our patients. So as long as you have a doctor who's highly ethical and cares about their patients, then they'll do the right thing. So here's kind of the top of the tear. We're almost done. I got 5 minutes left. There's just a lot of, you see all the blue stuff is the herniated disc. And that shouldn't be there. It should be deep inside where we already left, way back there. And but this stuff is wanting to come out through the tear, and it's stuck down right here to the tear, to the annular fibers. And this is where all the inflammation was occurring. This is a battleground. This is the front line of the battleground between herniated disc and annulus. Herniated disc and the inflammatory system. This is what needs to be cleaned up. We call it an annular debridement. And again, for those of you who are veterans at watching my surgeries, this is what separates the Duke laser disc repair from every other spine surgery in the world. We're the first and only surgery in the world right now that does an annular debridement. That's why we're able to get rid of 95% of back pain or neck pain from a herniated disc, because we do this right here, the annular debridement. Nobody else does it, which is why their results are not as good. Luis,
Yes, sir.
I really like this laser.
Good, good. How about that tank? It's good?
The tech is awesome, doing a great job.
How about your foot? Is good?
My foot is not good. My foot is good minus my left toe. Huh? Man, I'm getting fogged up again too, but standby laser. So there's a little bit of disc material there that I want to get out because it's not coming out. Yeah, my Advil's wearing off. For sure. My toe's starting to tingle. Is that okay, Dr. Santiago?
That should be okay.
You want to sneak under there and give me a block or something so my toe stops hurting? Maybe a spinal cord stimulator for my toe pain. I'm sure we can find one of our pain management doctors locally in Brevard County to do that. Oh, ingrown toenail, spinal cord stimulator. Hemorrhoids, spinal cord stimulator. Right? I'm not making this stuff up. I wish I was, but I've seen so many people abuse that procedure. I'm glad Dr. Patel's talking about it tonight. So yeah, those of you who are interested in learning more about spinal cord stimulator, tune in to Duke Spine Institute tonight, because we're going to be broadcasting on that procedure and the indications and technique and how it works and what it's good for. Definitely not good for herniated disc, spinal stenosis, radiculopathy, spondylosis, degenerative disc disease, spondylolisthesis, scoliosis, kyphosis, facet arthropathy. None of those should be treated with it. It's good for things like maybe complex regional pain syndrome or post-herpetic neuralgia, right? Or some type of neuropathic pain like diabetic neuropathy or mononeuritis multiplex, but phantom pain. You know, everybody knows what phantom pain is? That's pain from the Phantom. Not the Phantom of the Opera, but if you've ever seen the movie Zohan, the Phantom is the terrorist in the movie. Right, Luis?
Yes, sir.
Have you seen the Zohan?
Yeah, I saw it.
Oh, I love that movie. It's so good.
Don't mess with the
Don't mess with the
zone.
Zohan. The Phantom. All right, see what happens when you don't ask questions? I start talking about movies. Like Godzilla, Zohan. If you haven't seen the movie The Zohan, you have to see it. On my recommendation. Great movie. Very, very funny. Fizzy Boobla. Fizzy Boobla. Right? I just like Adam Sandler. He's just so funny. What was that golf movie he was in? Happy Gilmore. Great movie. He's done some really good movies. Well, I think we're just about done here, folks. I'm kind of looking at this, and to me, there's at 12 o'clock, you can see the epidural space, fat veins going across there. And really, we've gotten the herniation out. I think we're just about done. Any questions? This would be a good time to type them up, because what I'm going to do is head over to the conference room and answer your last few questions you might have, and then we've got that conference or seminar tonight, which will be live streamed. You all can watch it. And don't forget to join the Duke Spine Institute's Facebook group called Spine Surgery Support Group. Spine Surgery Support Group. The Spine Surgery Support Group is a public group. It's closed, so you have to request permission to join, but I give everybody permission to join. And it gives you an opportunity to ask questions when we're not here, when we're not doing a surgery broadcast. You can ask any kind of question about back or neck problems, spine problems, even insurance issues, healthcare issues. And it's an opportunity for everyone to kind of share information, experiences, ideas. It's also an opportunity for me to answer questions. So if you want to join the Spine Surgery Support Group, I encourage you to do it. As far as the app goes, our app is launching tomorrow. We just had a meeting with Apple today, and right, Zach? Or actually, they have to review the app. So we're going to have the app out tomorrow, up for review, but apparently Apple has to review the app. I think it's going to take about 4 days. So even though we're ready to launch the app, Apple is going to have to take some time to review it. Isn't that accurate, Zach?
That's about right, so hopefully early next week.
All right, so we'll have it submitted tomorrow, but the app development team is going to have to sign off on it. So just a little bit more patience. I apologize. We've never done an app before. It's our first one, so we're just learning the ropes as we go. But it all makes sense, and the app is going to be unbelievably amazing, honestly. I think you're all going to love the app. Zach has done a great job of programming it, putting it together, writing it. And Sonny and I and Zach have worked long hours together to build the content and the user experience and make it amazing. I'm really excited about it. It's going to be your gateway and point of contact with Duke Spine Institute for anything from video conferencing, MRI reviews, getting questions answered. We're going to ask all of our patients to download the app in the waiting room at the clinic so that we can actually use the app to show them what their diagnoses are. And we're going to build a playlist, a diagnosis list for each patient on their own personal phone. They'll be able to take it with them when they leave, obviously, and then reference the diagnoses that we've made and the treatment plan. That's all on the app, built into the app. You can also arrange video conferences through the app, and a lot of other interesting things. Testimonials, watch surgeries, join the Facebook group, Spine Surgery Support Group. So look forward to that launch next week. I am done. Laser off. And again, this is our second disc. The nerve root is over here. It looks like I might have to grab a little piece of disc there. See if that comes out. Maybe sitting underneath the root in the foramen. It's just annulus. That's just the torn annular fibers. Let me see, take it. All right, this looks good. Let me see that laser. I don't want to gild the lily, but I also don't want to leave something. All right, we're ready to wake this young lady up. That laser off? Very good. Yep. Happy with that? So go ahead and type up your questions, and I'll answer them for you as soon as I get to the conference room. Scope off. Just looks a lot more watery for some reason. Why is that?
Because it's diluted.
Diluted?
Yeah,
Why?
because it's concentrated. Yeah.
Talk about the depot.
Yeah.
It came in 40 milligrams and 1 ml.
Yeah. Oh, so you
and
wanted it.
40 and 5.
Oh, okay. But is that different than normal?
You dilute in what?
Huh?
Yeah, normal saline.
In lidocaine, 2%. Just kidding. All right.
It's different than 2 months ago. We've had these for about 6 weeks.
Okay. All right, very good. Well, thank you, everybody. Great work today. You all did an amazing job, team. You are the best team in the world. And I know we're losing one of our team members, right?
Today, this is her last day.
Tomorrow's your last day, and because you left the company gracefully, you always have a position here. For people who don't show respect to the company and leave improperly, they don't. But you do, because you gave us plenty of notice, and we appreciate your years of service. I'm going to put EVL as 4 cc's. So we did a DLDR. This was the right side, correct? Everybody agree? Right. L3445. All right, I'm heading over your way, Zach, to answer questions for the audience. So, thank you. Dr. Duke Majan here, and we've just wrapped up a two-level is in two discs, two disc levels, two-level Duke laser disc repair. And our patient is just getting ready to recover. We're putting the bandage on and getting the sheets and drapes off. We'll be moving the patient from the operating room to the recovery area in a few minutes, and there she will recover for the next 45 minutes and then go home. So what questions do we have, Zach, from our audience?
We have a question. Someone's asking, are you able to do this surgery on someone who is obese?
Great question. So somebody is asking, Dr. Duke, are you able to do this surgery on a patient who is obese? So the answer is simply yes, we can. As a matter of fact, to be quite honest with you, I know it's hard for most of you to tell, but I would say 3/4 of our patients are obese that we do the surgery on. You don't notice it because they're covered by drapes. So being obese is not a reason not to do the surgery. I get a lot of questions about age limits and whether losing weight would work, but losing weight won't work. It's not going to fix your back pain. I don't believe it does. Maybe 1 in 100 patients will get lucky and their pain will get better when they lose weight, but we have lots of skinny patients that have back pain from herniated discs. We have heavier set patients as well. But being obese is not a problem. Being, morbidly obese, which is, I think, three times or 3 standard deviations above the normal for normal weight, is morbidly obese, I believe, and even a morbidly obese patient we can do most of the time. I would say we could probably do patients up to about 350 pounds. Over 350 pounds, we might, depends on how tall the patient is, but for the most part, doing a lumbar laser on a 350 pound patient or less is definitely doable. Next question. So that was our last question. Today was an interesting day looking back and reflecting on it. Our first laser surgery went very well. The patient left home. She has no more pain in her back, and she's very happy. She's a workman's comp patient, meaning that she injured her back while on the job years ago, probably in the 90s, I think. And she had put off surgery because she wasn't interested in what was being offered throughout the years, and then now the endoscopic laser surgery is available, so she wanted it done. She injured her back in New York, I believe, and her husband also had surgery with me. The second case was another gentleman who had a work-related back injury, and he had a fusion done, but in my opinion, I think the reason he's having problems is, number one, adjacent segment disease. The disc below the fusion went bad, causing back pain, leg pain, but also where the fusion was done itself, they didn't clean the discs out properly, so of course the discs are there pinching nerves, irritating nerves, and causing pain. So that patient we try to get away with, rather than doing an additional level fusion below at L5S1, which would require that we take all the old hardware out from L2 to L5, we decided, and the patient wanted, to just move forward with trying the laser surgery. Normally it could work and it's not a problem, but in the case of our patient today, we're not able to gain access to the neural foramen safely because of the bone spurs from his issue with his L5S1 disc, plus the bone spurs from the surgery that he has had done already, the fusion. Those combined together kind of was pushing the needle laterally to the side and not letting me get to where I needed to be. Well, unfortunately, what's lateral to Parvin's Cambin's triangle is the nerve, and we kept hitting the nerve. So, rather than injuring the nerve with doing the surgery through the nerve, we decided that the best course of action was to hold off and regroup and probably do an open surgery. Right there. And that's what I talked to that patient about, and it's what he wants to do. So we're going to put in for the insurance to cover it, and we'll get his surgery done in the next week or two. You'll be able to see a revision fusion surgery with a Duke spinal fusion. The final patient we just did was a 2-level lumbar Duke laser disc repair. She had 2 herniated discs with spondylolisthesis or slippage of the bones at L34045. She was symptomatic with back pain, pain going down into her right leg. with radicular symptoms. She did not want a fusion. She wanted the laser surgery. We did it with one incision. Both discs were repaired using a laser. She'll do fantastic. We'll probably see her next week and post her film. Dr. Patel will be starting his seminar tonight on spinal cord stimulators, and you're all welcome to tune in with the live stream to learn. All right, Dr. Ardugmajan, and I hope you have a good evening, and we look forward to seeing you next week.